Aortic valve stenosis is the most frequent cardiac valve pathology in the Western world, with an incidence that is growing as a reflection of the rapid aging of the population. As a result, there is an increasing number of elderly patients eligible for a prosthetic aortic valve replacement who present with greater morbidities and underlying risk factor profiles. Based on extraordinary short and long-term outcomes, conventional aortic valve replacement is the gold standard approach for the treatment of symptomatic severe degenerative aortic valve stenosis. However, the greater morbidities and risk profiles on the contemporary patient population has driven the development of minimally invasive interventions such as percutaneous transcatheter aortic valve implantation, as well as techniques and technologies to reduce the surgical trauma. The latter include minimally invasive approaches and sutureless prosthesis. While the concept of utilizing a rapid, simplified, non-suture mechanical fixation of the valve prosthesis to lessen the bypass time was first introduced about 50 years ago, sutureless and rapid deployment valves have been redeveloped in the last few years based on modern experience with TAVI. Sutureless and rapid deployment aortic valves are biological pericardial prostheses that anchor within the aortic annulus with no more than 3 sutures. There are 3 commercially available prostheses, including the 3F Enable, the Perceval S, and the Intuiti Elite. The 3F Enable and Perceval S sutureless prostheses utilize the memory of the nitinol metal frame, which deploys and positions the valves with no sutures required in the case of the Perceval S valves and 1 suture for the 3F Enable valves. The Intuiti rapid deployment aortic valve prosthesis operates by a different mechanism, based on a balloon expandable stainless steel and cloth-covered frame, which is implanted with the aid of a balloon catheter delivery system. 3 sutures are required in the case of the Edwards Intuiti valve prosthesis. There are several key similarities between sutureless and rapid deployment aortic valves versus conventional prosthesis for AVR. Both approaches will require surgical incisions, which can be performed using a full median sternotomy incision or alternatively the use of minimally invasive incisions such as mini sternotomy and mini thoracotomy. Similar to the traditional approach, sutureless valves does not preclude the need for cardiopulmonary bypass and aortic cross-clamping. In terms of surgical technique, the diseased valve is completely excised in either approach to allow for the implant prosthesis to be deployed and positioned to minimize as much as possible paravalvular leak. There are also several critical differences between the implantation of a sutureless valve versus a traditional stented aortic prosthesis. The nature of sutureless valves is that these do not require extensive placement or tying of sutures. Subsequent to diseased valve excision, the sutureless and rapid deployment valve prostheses are sized and deployed, requiring no more than 3 locking sutures to adequately attach to the aortic annulus. This may translate into reduced operation duration and thus may facilitate minimally invasive access, which has traditionally been thought to be associated with longer operative times. So why consider sutureless valve? There are 3 main reasons. The first one is to reduce cardiopulmonary bypass and cross-clamp times. It is well established in the cardiothoracic surgical literature that extended cardiopulmonary bypass and aortic cross-clamping duration are significant independent risk factors for mortality and morbidity in cardiac surgery. A recent retrospective analysis of more than 900 patients with aortic valve stenosis demonstrated that aortic cross-clamp time was a significant independent predictor of cardiovascular morbidity. This was confirmed in this particular study as the presence of low cardiac output, stroke, acute kidney injury, or operative mortality. A reduction in aortic cross-clamp resulted in better morbidity outcomes, particularly in patients with a reduced left ventricular ejection fraction less than 40% or in patients with diabetes mellitus. Therefore, any technique which shortens cross-clamp or cardiopulmonary bypass time will have the potential to decrease the risk of complication and reduce long-term mortality, even after considering the latest and most sophisticated methods of myocardial protection. The main advantage offered by sutureless AVR is a reduction in cross-clamp and cardiopulmonary bypass duration due to fewer placement and tying of suture. From a recent meta-analysis by Phan, 12 observational reports were identified for quantitative analysis. The pooled cross-clamp and cardiopulmonary bypass durations for isolated AVR using a sutureless prosthesis was 56.7 and 33 minutes respectively, half of that compared to values reported by the STS national database for conventional AVR. Thus, the reduction of cross-clamp and cardiopulmonary bypass time with sutureless or rapid deployment aortic valves may improve results in all patients, but may be particularly beneficial in patients with significant underlying comorbidities and higher surgical risk profiles. As such, the indication for operation is appealing in higher risk patients and may become standard of care once long-term results have demonstrated safety, efficacy, and durability. Additionally, the use of sutureless AVR may be particularly reasonable in higher risk patients who need to undergo AVR with concomitant cardiac surgery, complex operation with multiple interventions to minimize operational durations and improve outcomes. For example, in our institution, sutureless AVR was a valuable option of treatment in an 85-year-old woman with severe aortic stenosis and 3-vessel coronary disease complicated by preoperative moderate LV dysfunction and renal insufficiency. She received successful full surgery with complete myocardial revascularization and sutureless AVR with considerably short operative times. In our meta-analysis, combined intervention with sutureless AVR was about 1/4 of all cases. Sutureless AVR is also valuable to facilitate minimally invasive aortic valve replacement. Minimally invasive aortic valve replacement has shown to produce similar efficacious outcomes as conventional AVR, but with decreased hospitalization, reduction in external wound complications, reduced surgical trauma, and improved cosmesis. However, the minimally invasive approach has not disseminated widely since associated with greater technical difficulty, longer cross-clamp and cardiopulmonary bypass durations, and a longer and more difficult learning curve. As such, opponents of minimally invasive AVR claim that potential advantages are counterbalanced by longer operation durations, which are associated with poorer outcomes. Furthermore, no study has demonstrated any survival advantage or marked reduction in major complication after minimally invasive aortic valve replacement compared with conventional aortic valve surgery. A recent meta-analysis of more than 12,000 patients from 50 comparative studies demonstrated similar conclusions. One aspect of the technical difficulty which arises in minimally AVR is the placement and tying of sutures through a smaller incision. Therefore, the use of sutureless aortic valves has the potential to simplify the minimally invasive AVR procedure by avoiding the need to suture the aortic valve to the aortic annulus through a small incision and limited surgical field. It is likely that minimally invasive AVR with the reduction in operative times using sutureless prosthesis may record further improvements in results, particularly in critically ill patients at the highest operative risk. Studies have shown that there has been a significant increase in the use of minimally invasive approaches in sutureless aortic valve surgery. It is likely that with time, as surgeons traverse the learning curve, sutureless aortic prosthesis will be increasingly used to facilitate the advantages of the minimally invasive approach without the detrimental drawbacks of increased cross-clamp and cardiopulmonary bypass durations. Additionally, current results suggest that sutureless AVR may be associated with excellent hemodynamic outcomes, with very low transvalvular gradients and a reduced risk of patient prosthesis mismatch. Although matter of a continuous debate, PPM has been associated with reduced symptom reliefs, lesser regression of left ventricular hypertrophy, and reduced event-free late survival. Patients who are particularly at risk of PPM include those with smaller annulus. A study by Wilbring showed that patients with small aortic annulus were found to be predominantly small, obese, elderly females with multiple comorbidities. As such, aortic root enlargement and use of stentless valves may assist in reducing PPM complications. However, these interventions add technical complexity and certainly extend operative duration significantly. These high-risk subset patients will more likely than others to benefit from sutureless AVR, a promising alternative with demonstrated excellent hemodynamic performance that facilitates minimally invasive and less traumatic approaches while minimizing CPB and aortic cross-clamp durations. Paravalvular leak is an important complication that always has to be considered when assessing the outcomes of implantation of a prosthetic valve. Recent evidence from TAVI trials demonstrate a significant correlation between PVL and poorer outcomes. In the patient trial, EchoCore lab results demonstrated a PVL prevalence of 12%. Paravalvular leak was demonstrated to be a significant predictor of one-year mortality. Different from TAVI and similar to conventional AVR, the nature of the sutureless AVR approach is that it involves excisions of the calcified valve and prosthesis placement under direct visualization on a still heart, which may reduce the risk of misplacement and paravalvular leak. In a recent meta-analysis, the pooled rates of paravalvular leaks was 2 to 4% at latest follow-up, comparable to rates reported for conventional AVR. The study also showed that paravalvular leak complications appear to be a function of the sutureless AVR learning curve with significant reduction over time. There may be several drawbacks associated with the sutureless aortic prosthesis. First, while sutureless AVR is designed to simplify the technical challenge of AVR, the implantation procedure is quite different to conventional AVR and requires proctoring for the surgeon to traverse the learning curve. Sizing the valve is absolutely important, and if the size is not ideal, paravalvular leaks, valve migration, and root dehiscence will be catastrophic, resulting complications. Indeed, a recent case report demonstrated transcatheter aortic valve-in-valve implantation as a procedure to rescue a leaking sutureless self-expandable valve. This may be a valuable option in elderly patients with significant comorbidities where traumatic alternatives such as conventional AVR may not be ideal. Given that sutureless AVR is still a surgical procedure with cross-clamping and cardiopulmonary bypass, associated complications will still be present. The lack of long-term data with sutureless AVR should be always considered when implanting a sutureless or rapid deployment aortic valve prosthesis in a relatively young patient. In this current issue of Annals of Cardiothoracic Surgery, a systematic review and meta-analysis was performed by an international collaborative group of surgeons performing sutureless surgery. A total of 12 relevant articles were identified and included for the analysis. The pool results demonstrated a reduced cross-clamp and CPB duration of 67 and 46 minutes for all sutureless AVR, respectively, which are lower compared to values currently reported in the literature for AVR using conventional prosthesis. Complications including all-cause mortality, stroke, and endocarditis were low as well. The rate of paravalvular leakage was low, 3%, and excellent hemodynamic outcomes were achieved at up to 12 months follow-up. There have been several comparative studies published on sutureless versus conventional AVR. Shrestha found that cardiopulmonary bypass and cross-clamp times were significantly shorter in the sutureless valve group compared to conventional. However, at up to 5 years follow-up, no significant differences in mortality was noted between the cohorts. Gilmanov published a series of 515 patients undergoing right anterior minithoracotomy AVR, 269 with conventional prosthesis and 246 using sutureless prosthesis. Cardiopulmonary bypass and cross-clamp time was significantly shorter in the sutural group, while in-hospital mortality, perioperative stroke, and pacemaker implantation were comparable. In a German single-center propensity match study by Polari, 82 matched pairs of sutureless AVR and conventional AVR were studied. There were no differences in hospital deaths, but cross-clamp and cardiopulmonary bypass was significantly shorter in the sutureless group. Also, and interestingly, sutureless AVR was associated with lower cost for diagnostics and hospital stay. Borger performed the only randomized multicenter trial published today on minimally invasive sutureless AVR versus conventional AVR. 46 patients with Edwards intuitive sutureless valve was compared to 48 patients with a conventional aortic valve replacement. Similar to previous studies, minimally invasive sutureless AVR was associated with significantly lower cross-clamp durations, with no differences in early clinical outcomes or quality of life measures between the two groups. Sutureless AVR patients had superior mean transvalvular gradients. Overall, the authors conclude that sutureless valves may have a role in facilitating minimally invasive aortic valve replacement. Santerpino compared 37 propensity matched pairs of sutureless AVR and TAVI cohorts. There was no difference found between the two groups in terms of in-hospital mortality, pacemaker implantations, or neurologic events. However, higher paravalvular leak was noted in the TAVI group compared to sutureless group. Due to improved midterm survival in the sutureless group, the authors concluded that sutureless valves may be the ideal first-line treatment for patients in the gray zone between conventional AVR and TAVI. Donofrio performed a multicenter propensity-matched analysis of 349 conventional surgery, 38 sutureless surgery, and 566 TAVI procedures. There was no difference in 30-day mortality between the cohorts noted. There was a non-significant trend for lower aortic regurgitation, pacemaker implantation, and renal replacement therapy in the sutureless group compared to TAVI. However, other perioperative complications and hemodynamic outcomes were similar between the groups. Munoreto compared 53 patients with sutureless implants and 55 patients who underwent TAVI procedures. TAVI was associated with higher pacemaker implantation, peripheral vascular complication. No differences in hospital mortality was noted. At 24 months follow-up, survival-free from major adverse cardiac and cerebrovascular events was worse in the TAVI group compared to sutureless group. Overall, the current evidence suggests that sutureless AVR is a valid alternative to conventional AVR with similar clinical midterm outcomes but shorter CPB and aortic cross-clamp duration. Compared with TAVI, sutureless also has similar clinical results for high-risk but operable patients, but may be associated with lower incidence of paravalvular leak, likely due to accurate decalcification of the diseased valve. Valve decalcification should also theoretically reduce brain microembolization compared to TAVI. However, this speculation requires further investigation in future studies. Nevertheless, there is still a paucity of robust clinical evidence for sutureless AVR, limited to short-term studies with small sample sizes and inadequate statistical power. The lack of robust data prevents the development of high-quality evidence-based guidelines. An international collaborative effort will be required to allow sufficiently powered analysis to best evaluate sutureless technology. Recently, the International Valvular Surgery Study Group has been formulated to conduct the Sutureless project, set to be the largest international collaborative group to investigate this technology. The International Valvular Surgery Study Group comprises over 33 surgeons from 25 centers worldwide, and it is envisaged that this global collaborative effort will shape clinical guidelines, optimize patient outcomes, and set future direction of research for sutureless AVR. In conclusion, despite the recent introduction of sutureless technology, current evidence suggests sutureless AVR as a promising, feasible option, with the major advantages being a reduction in cross-clamp and cardiopulmonary bypass duration. An international collaborative effort led by the International Valvular Surgery Study Group will hopefully set up to provide clinical robust evidence for the safety, efficacy, and long-term complications profile for sutureless aortic valve technology. Thank you for the attention.